Hello, everyone. Welcome to webinar number 43. I'm Neeti Daftri here on behalf of the Circle of Cleft Professionals. At today's webinar, we will zoom in on multidisciplinary cleft care in the Philippines, where Noordhoff Craniofacial Foundation, the NCF, has been actively engaged for over 2 decades. We will have the opportunity to hear from Dr. Bernard Tansipek, NCF's Philippines President, about the protocols they employ in delivering care from infancy until adulthood, and the strategies they've been using over the years to overcome hurdles in implementing comprehensive care. We will have simultaneous interpretation in Spanish for the entire duration of this webinar, for which we have Ben and Eva joining us from Chile. At the bottom of your screen, you will see an interpretation button. If you would like to hear the rest of this webinar in Spanish, please click on that button and select Spanish. If you would like to continue in English, please select English. So this is our agenda for today's hour-long webinar. We will begin with the COCP update. We will have a presentation by Dr. Bernard Tansipek for the first half hour. This will then be followed by questions and discussion for the remaining half hour. What is the COCP? We are a network of nearly 800 cleft professionals from over 80 countries who have an interest in promoting comprehensive cleft care in resource-constrained settings. And we would like to thank these 11 international charity organizations, all of who have come together to make the COCP and all of its activities possible. Over to you, Hugh.
Thanks, Neeti. We're delighted to be here. This is one of the sponsors, as you saw on the previous screen, is Noordhoff Craniofacial Foundation Taiwan. And I think I've seen Linus Lee, one of their leaders, on this call. And he introduced us to Dr. Bernard Tansipek, and we're delighted to know a little bit more about Noordhoff Craniofacial Foundation Philippines, which is a separate organization, but very much linked and along the same lineage of Dr. Noordhoff's innovative leadership in Asia. And so this is really a key topic, as a rallying feature for all of the Circle of Cleft Professionals. We embrace comprehensive cleft care. We say we're all on this journey towards providing that year-round multidisciplinary care that we know leads to better patient outcomes. And so we're delighted to hear a little bit more about how that has been developing in the Philippines. So I've just been chatting with Dr. Bernard this morning about their model. I think you're going to find it to be super interesting to see this commitment to provide comprehensive cleft care, that starts at birth and goes all the way till the patients become adults. And I think all of us, for our own context, will be able to sort of map along and say, what has been a challenge we faced in our own context in providing that year-round care where we work, and then also what can we learn from the Philippines experience. So I don't want to spend too much longer on this introduction. I want to get right into the topic. But as you can see at the bottom, Dr. Bernard Tansipek is a consultant surgeon at several hospitals, including Philippine General Hospital, and he's past chairman of the Philippines Board of Plastic Surgery. And he's a founding member and board of trustees for NCF Philippines. And he's been this president for, hey, this is 10 years. Congratulations. The decade of leadership, Dr. Bernard. Wow, that's lots of learning over those 10 years, I'm sure. We'll pass it over to you. So if the technology works, we'll stop sharing our screen. Please go ahead and share yours. And again, as people have been putting in the chat, if you've joined us a little later, feel free to greet us along the chat. Along the way, if you have comments or questions, please do record those, because I know Dr. Bernard is going to save a good amount of time for us to talk about what he's brought up and think about how it applies to our own context. So please, Dr. Bernard, take it away. It looks like the technology has worked.
All right, thank you very much. I'd first like to thank Linus and NCF Taiwan for inviting me to lecture here. Also would like to thank our staff in NCF Philippines, especially Dr. Cabrera, who provided a lot of the data that I'll be talking about. So NCFP, Noordhoff Craniofacial Foundation Philippines, is in the Philippines. I just want to give a little disclosure. Most of the patients here are patients of NCFPI, and they have signed their consents to have their pictures presented. And I'm presently president of the Board of Trustees of NCF. So a little profile about the Philippines. We are a lower middle income country. The average annual family income is about 307,000 pesos, which is about $5,500 US. We have a population of 113 million, and 18.1% are living in poverty, according to World Bank statistics. We have a lot of healthcare issues because 50% of the population do not have or have difficulty accessing primary health care because of the inequitable distribution of facilities. Most of them are in the urban centers. And also, we have a shortage of physicians and nurses as there's a big brain drain. A lot of our healthcare professionals are being recruited elsewhere around the world as they are open for Filipino healthcare professionals. So in the Philippines, the cleft rate is about 1 in every 750 babies. With our birth rate, it's approximately about 4,500 new cleft babies born every year. So it's the third most common birth defect in our country. Unfortunately, our national healthcare insurance has inadequate coverage of our lip repair, palate repair, alveolar bone grafting, and orthodontic surgery. It only covers, for example, palatoplasty is only half of chyloplasty coverage. For orthodontic surgery, they will only cover only Lifort 1 or the BSSO, and the titanium plates are an out-of-pocket expense. Dental care is not covered, so NAM, pediatric dental and adult dental care, orthodontics, prosthodontics are all out-of-pocket expenses. Speech therapy is not covered. So again, this is an out-of-pocket expense for our cleft families. So the sequelae of this undercoverage, non-coverage of the treatments that our patients require is that nasoalveolar molding is rarely done in the general dentistry community. Cleft surgeries are pushed to mission-based or safari surgery type given by non-government organizations. There's very poor dental care, poor oral hygiene in the pediatric and adult age group. In fact, in Southeast Asia, we are the worst in terms of dental care. For children between 7 to 9 years old, 90% are kids, non-cleft children, meaning everybody will have some sort of dental caries between the age 7 to 9 years old. So speech therapy is an out-of-pocket expense. So in the end, we have a lot of delayed treatment, inadequate or unsatisfactory treatment. So we have a lot of social issues because mission type of treatment for clefts is, there's a lot going on in our country. So this is just my personal perception of what happens when you have a lot of mission treatments for cleft. It changes the perception of the disease or the problem by the parents of our cleft patients, mainly due to inadequate education. Again, for the specialist, it also does change their perception of the problem because of inadequate education. So for our parents or guardians of the cleft patients, the parents develop these misconceptions and believe that cleft treatment is a mission activity, that the local infrastructure does not prioritize cleft patients. So this is partially true. And the international team is better because the local team does not do this type of surgery. For the cleft, the specialists or the primary care doctors, they end up believing that the mission model is the standard of care. So they don't prioritize formation of a multidisciplinary cleft team, but instead they prioritize and organize the cleft missions instead. So how do we solve the cleft challenge under the inspiration of Dr. Sam Noordhoff and NCF Taiwan? We pushed for a multidisciplinary or an interdisciplinary type of cleft care center. We pushed that there must be a close cooperation between our orthodontist, prosthodontist, dentist, surgeon, pediatrician, speech pathologist, psychologist, and our social worker. So, and as these specialties get together, it must be that each specialty has some sort of an idea what the other specialists are doing about when it comes to cleft care. And so, we have to establish these dedicated local centers for our patients, making our patients the center of the entire project. So we have to select, we had to select a group of specialists who have a passion for multidisciplinary care management. They must be willing to staff the cleft clinics consistently so that we have a continuity of care and a collaborative type of care. So since 2003, these are the number of surgeries that we've done. It's about 6,092. Another important thing that I am trying to advocate is that there must be multidisciplinary discussions within the cleft care setting. So we made it in such a way that once or twice a week, we would hold our clinics simultaneously in the same sitting, and any problems about cleft patients can be discussed on the spot. So multidisciplinary discussions are essential. So here we have pictures of me talking with our dentists, with our pediatricians, with our orthodontists, right on the spot when the patient is there. And then we have to set up a base for our patient to follow up. So we have 3 locations for NCFP, Our Lady of Peace Hospital, the Philippine General Hospital, and the Smiles Craniofacial Center. When we started, we have to provide the fundamentals, which is good pediatric care, because most of our patients are babies. We have to make sure that we have a well baby consultation and a nutritional upbuilding protocol so that we can make sure that the patients are healthy prior to undergoing any surgery. We have to screen for childhood tuberculosis, malnutrition, respiratory disorders, cardiac issues, and neurologic issues. So any patient who have any secondary morbidity, comorbidities are brought to the Philippine General Hospital, which is a tertiary care center, so that an ICU is ready on hand whenever we have to do patients who have secondary comorbidities. So we have to start with the fundamentals. Again, we provide NAM, chyloplasty, and palatoplasty. NCFP is a fervent advocate of nasoalveolar molding because it enables our surgeons to do a better job. And not only that, it helps with the nutrition upbuilding and feeding for these patients. So when we started, we had to be ready to treat the sequelae of delayed and or inadequate management. We had a lot of adult unrepaired cleft cases, redo or re-repair cases from poor cleft lip and palate repairs, and we had to deal with the poor dental care that the patients, the situation of the patient's dental condition. And these patients have to do catch-up treatment, meaning we have to do simultaneous surgeries together, like bone grafting and velopharyngeal insufficiency surgery at the same sitting, so that they could catch up and be in the have their treatment done as soon as possible. So these are some of our unrepaired adult cases. Our oldest patient is this lady who is 42 years old when she had her primary cleft lip repair done. So this is a list of all our cases starting in 2011. As you can see, the delayed cases, meaning patients older than 5 years old, has been slowly going down. However, sadly, if we look at all these delayed cases and see them as a group, those patients who are above 18 years old still make up about 40% of all our delayed cases. So we still get these adult unrepaired cases until now, sadly. Then we have to deal with a lot of these re-repair cases. So these were surgeries done in the mission setting, and unfortunately they dehisced, so we had to come back and do re-repair. Just this, where this is one case where the premaxilla extruded out of the surgical repair. Then we had to do lip revision, such with an abbey flap, to create a better smile for our patients. All right, so since dental care is not covered by the National Health Insurance, we had to partner with a pediatric dentistry center. See, this is a training institution for pediatric dentistry. And we also partnered with the Association of Philippine Orthodontists. So they provide a lot of the pediatric dental care as well as the orthodontic needs of our patients. So since 2009, we have done these much sessions for our pediatric and adult procedures done mostly by our trainees and volunteer dentists and orthodontists. So here we can see our pediatric dentist doing their thing. And here is one of our orthodontists doing surgical orthognathic surgery planning with me. All right. Because basic dental hygiene is very poor in our country, we had to hold basic dental hygiene care, such as toothbrush lectures for our mothers as well as our patients. So here, and we hold regular mothers classes for our cleft patients, to not only for dental care but for nutrition as well. And then we have to do our speech therapy classes in cooperation with the trainees of the University of Santo Tomas. So our speech pathology interns rotate with us every 2 to 3 months, and they're exposed to speech therapy for cleft patients. And then we also need our nasopharyngoscopy to evaluate all our cleft palate repairs and see if these patients would require secondary palate lengthening for velopharyngeal insufficiency. So as time went on and we were able to meet the cleft lip and cleft palate needs of our patients, we expanded our care to provide alveolar bone grafting, orthodontics, orthognathic surgery, and prosthodontics. So this is one of our patients. She actually came to us quite late, already at 17 years old. We had to do alveolar bone grafting, and then orthodontics, then underwent orthognathic surgery, then lip revision with rhinoplasty using ear cartilage graft. So this is her after 2 years of treatment with us. This is her final occlusion at the end of the debonding. So this is one of our the sequelae of our poor dental care. She's just 22 years old. Look at her occlusion. Look at her dentition. Oh, she lost almost all of her maxillary teeth, and there's still a lot of caries for her. So we've had to do a lot of dental work, then orthognathic surgery and an abbey flap to fix her upper lip, then prosthodontics to give her a good occlusion with what she has remaining. Then, because Dr. Noordhoff always pushed us to push the envelope, and we went into facial cleft repair, craniosynostosis, and nasoethmoidal meningocele repair. So here is one of our facial cleft patients. They undergo, we see them early, nasoalveolar molding helps a whole lot to bring the lip segments together. Here he is at around 5. So his anophthalmic eye, the ophthalmology department of PGH was able to give them a prosthetic eye, give him a prosthetic eye for his anophthalmic right eye. Then we were able to do orthognathic surgery for a median cleft patient, facial cleft 0. This is her after the orthognathic surgery and after the rib cartilage graft for her nose. And we also, since nasoethmoidal meningocele is quite common in the Philippines, we get a lot of late repairs. So this is one of our patients. This is her after surgery, and this is the picture she sent me right before she graduated from her college. All right, and we have another case of combination of a meningocele and a facial cleft. We had to harvest from the parietal bone to cover the hole in her cranium, and this is her after a few weeks after surgery. So initially, our problem was to get our patients to follow up with us. So we had to, because a lot of them are quite poor, we had to set up the small jeep concept. So we designated pickup points in different parts of the city, and the patients would gather at this point, and a vehicle funded by the NCFP or another sponsor, such as the local government units, would bring them to our hospital. So this made transportation more accessible, and it promoted our tie-ups with other NGOs and local government units. So this small jeep concept increased our follow-up rate so much. So I hope this idea you can pick up on this idea. Then we had to establish our parent support group and peer support groups. So here we are having a painting workshop for our patients. Then we got our patients to visit Asilio de San Vicente de Paul. So this is an orphanage. And so from the patients were now themselves giving care. So the roles have been reversed from being a receiver of care. They are now experiencing being providers of care for the orphans in this institution. So one of our major problems that we still face is the awareness of the cleft condition. So in a survey done among our patients, the average age that the patients become aware that they have a cleft is around 7 years old. So this varies from 3 to 14 years old. However, less than 50% of the patients said that their own parents explained the cleft condition to them. So they learned their cleft condition, that they had the cleft, from being bullied, from being isolated, and being made to feel different, because their peers pointed out that they have speech issues, that they have some sort of lip deformity. So again, this is something that we have to face, and we're trying to get patients to start opening up and talking to their children about their cleft condition. So finally, in 2022, we became a Smile Train Cleft Leadership Center. But for me personally, I would like to think more of it as a cleft learning center. So we provide NAM training, lectures, and webinars on cleft care. We provide rotations for new graduates of plastic surgery programs, rotations for interns of speech therapy programs, and trainees of orthodontic programs. So advocating the paradigm of multidisciplinary cleft care. And again, we're able to expand our reach through word of mouth, through the internet, Facebook, TikTok, and Instagram. So Facebook is quite common, or quite a big thing in the Philippines. So we are able to reach more through Facebook rather than our website. Then I'd like to thank all our institution partners, especially Smile Train, Noordhoff Craniofacial Foundation, Taiwan, PGH Health, and Our Lady of Peace Foundation, Association of Philippine Orthodontists, and all these. So that's it. Thank you very much. If you have any questions, just I'm here.
Thank you, Dr. Bernard. Yes, well, there's lots you covered. I'm sure there are questions. I'll give everyone a second just to collect your thoughts. You know, what's something that stood out for you? We did have some chat going on through the presentation of some topics we might like to pick up on. As always, or if you're new, you're very welcome to put your hand up and let us know that you'd like to ask your question directly or make your comment. That's wonderful. If you prefer to type it in the chat, then I'll try to make sure that we get those questions raised as well. And so I see there is a question off the top, and let's just start there. Dr. Bernard, you mentioned a lot of issues that do connect into this idea of psychosocial care or awareness raising or that kind of support that comes in. How is that provided within your model? And that comes from Madeline on the chat.
All right. So with our model, we have a lot of patient advocates. So our patients themselves, they often post videos of their cleft journey on TikTok or Facebook. And from there, they get a lot of responses from other mothers who have cleft. Actually, one thing that struck out to me is one of my patients went to McDonald's, and one of the person on the at the cashier was a cleft patient who had unrepaired cleft palate, and my patient invited the cashier to go to our center and have his cleft palate repaired. So when we started out, the word of mouth was quite strong, and then Facebook came along, and we realized that almost 90% of our patients contact us through Facebook. So we decided to decrease all the billboards, all the flyers, because people just gravitate towards Facebook.
Lovely. So social media being a really important part. You mentioned this idea of cleft advocates. Is that a formal program that you have, or is that just your name for how people who move through your program spread the word?
Yeah, we try to inculcate that in our peer support group and our parent support groups. So a lot of them actually, because Filipinos are quite shy, so a lot of them now would tell me that when they see someone on the bus and there's a baby with a cleft, they would be confident to go, is your child being treated? Because my child was being treated, and they were and they open up the topic of the multidisciplinary care.
Lovely.
So
thank you. And I'm grateful for the shout out for parent and patient support groups. I think someone from the team will be able to post a link. That was a topic, as you'll remember, that we tackled in 2023 with our Solutions for Comprehensive Cleft Care conference. The idea of what are some recommendations for building that parent and patient support group. And we know the South Asian region is well advanced. So there's lots to learn from your region, and it sounds like that's well established within the Philippines. Lovely. Thank you, Dr. Bernard.
I have to credit NCF Taiwan because I got this idea from them. Their parent support group is like 100 times stronger than ours. Definitely.
Lovely. We're all learning from one another. That's what's there. So thank you for that. Now let's move back to where you started. This idea, and this does connect into working with parents and patients around their perceptions. How did you move? What was the key piece, or what is the ongoing piece that sort of convinces parents and patients that they can look to local surgeons like yourself and local teams to be able to provide this care? When we talked a little bit more about this cycle of when there is missions, people become reinforced in that perception that only foreigners are equipped to provide this. This is a kind of condition that foreigners are best equipped. What was that process like? And I know there's some others on this call who have had a similar experience when in their countries missions were the dominant model for cleft care provision for so many years. What was the breakthrough for you?
Right now, I'm still dealing with the issues, because even among my colleagues in the surgery world, there's still a lot of doing missions. So it's just that the patients who have good results, and you just have to keep on harping, and like a broken record, keep on going, and trying to get people to see that with multidisciplinary care, you can get better results. Actually, most of the information spreading, I guess, comes still from parents, because when they see that their children are getting better results, they spread the word.
All right, so it's one thing
I don't know, maybe maybe some other participant has some other ideas, because right now this is the only way I think you can do it when we want to spread our advocacy. It's to keep going. Like, I've been giving so many talks these past few years just to push for this multidisciplinary care setting, and I'm trying right now going down to the trainees, like medical students, dentistry students. I'm opening myself to lecturing to them and showing them that this is a better way to go.
Lovely. So, thank you, Dr. Bernard. So that's there's two key points I heard there. I mean, one was definitely that word of mouth, patients and parents who say, I had great care and was from a local team, and here's what goes on. And the second strategy you're talking about is working directly with professionals who might come across cleft, so that they understand also that there are resources and a care pathway that's acceptable and strong, that's local. Dr. Bernard's asked for the group, is there anyone else who has an experience, if you are in a context where mission-based care or having foreign volunteers is the predominant model, what else would you add to that strategy list for moving beyond that perception so that people do trust and embrace a care pathway that's led by local professionals in a year-round fashion? And I'll leave that hanging there, but if anyone wants to jump in, that was Dr. Bernard's question. I think we can all learn.
Hello, I'm Dr. Fayyaz from Pakistan.
Good to see you again, Dr. Fayyaz. What's been your experience?
Yeah, we have been running our cleft program since 2003, and we have my team has operated 46,000 free cleft surgeries in Pakistan and Afghanistan. We have a small hospital in Lahore where we work 6 days a week, and we provide free surgeries, we provide audiology, we provide speech therapy, we provide NAM, and we provide cleft orthodontic services. And 99% of these services are provided free of cost. Only my private patients, they pay. Otherwise, every patient is offered every service free of charge. And we do consult each other. I still remember 15 years back, when we did not have any speech pathologist in our team, whenever we get a secondary pilot patient, we usually make a toss whether we do speech surgery or not. But since we have a dedicated speech pathologist in our team, all of our secondary cleft palate patients go to the speech pathologist, and he will give his input. Dr. Fayyaz, don't do anything else. We can improve only by speech therapy. Or he can say he needs speech surgery to improve this speech.
So, Dr.
And now we also provide NAM to our all patients who report in the first week, second week, or third week of their birth. And we also do audiology once in a week. And we have identified many patients who were not speaking after surgery, that they also had audiology problems as well.
So, Dr. Fayyaz, it sounds like you're saying there's a lot of similarities between the model that you have in Pakistan and what Dr. Bernard is leading in the Philippines.
Yes, but we also do missions in Pakistan, because Pakistan is the 4th country in the world having more clefts after China, India, and Indonesia. We usually get 10,000 new clefts every year. That means we need at least 15,000 surgeries if 50% patient have lip and the palate both cleft. And we have many secondary surgeries coming to our center.
Wonderful. So that sounds like
So-
you're saying that there's a dual model in your
Yeah,
context where you
yeah,
have
yeah.
a year-round place where people can
Yeah.
access that care, but in
Yes.
light of the volume, that there still are missions that are going on in your context.
Because quite a majority of our population are still under the poverty line. They cannot travel to our center in Lahore
Right.
for coming forth and back. So we usually do 8 or 10 missions every year. But our mission model is quite different from the other models. We have a regular team. We do not invite any newcomer to our team to do the surgeries. We are 6 surgeons in the team. We run 7 operating tables during our mission.
Great.
We have 4 anesthesiologists. We usually move as a 55 members of the team.
Right. So
So
I'll just
every team member
stop
is
you
very
there.
much
I'll just
trained.
stop you there, Dr. Fayez. You've covered so many exciting topics and interesting topics. So definitely you pointed to the idea of Dr. Bernard helpfully pointed out 20%. So 1 in 5 families in the Philippines are below the poverty line, much higher percentage, making it that barrier to care of transportation, et cetera, even more important. I see Nan's point, but just to pick up one other thing that I'd like to talk about. Dr. Fayez was talking about speech therapy. Dr. Bernard, you mentioned that there's no coverage at all for speech therapy in the Philippines. So no hospitals employ direct. Is that just for cleft, or is that in general that speech therapy?
In general. So the only time you can get some sort of a speech therapy, maybe for maybe in some government hospitals, they have some speech therapists on the payroll, but these are usually trainees. So
Right.
what we did was we partnered with a training institution, and we have our speech therapist, Mr. Paulo Sison, who is is a very strict, strong advocate for cleft speech therapy. So he would guide all these students as they come through us.
Fantastic. So it's really been pushed to the NGO sector and leaders like you to be able to make sure that those speech therapists that are being trained that would ordinarily just go into private practice are then having the awareness of what being part of a multidisciplinary cleft team is, and then bringing them along to be able to make the kinds of consultation that Dr. Fayez was talking about around having that surgeons having that essential input from speech therapists when we talk about things like speech repair, surgical repair, etc. So very interesting. Nan, we'll go to you, please. What's your question?
Thank you, Hugh. Maraming salamat po, Dr. Bernard. I really
Wow.
appreciate the work you've been doing. It's extraordinary. And it's Manila based. It has to be. But I'm wondering, in the archipelago of over 9,000 islands, are you able or do you have funding support to bring patients and their families up to the capital to have the necessary treatment? And does this also mean that there's a lot more mission activity in the provinces? That's my question. Thank you.
All right. Yes. Yes. So right now, we one of our partners is Philippine Airlines. So this was before the pandemic. So right now, everything is up in the air. Before if you had some miles on your card, you could donate for a patient and her and mom. But right now, it's not no longer there. So we're also trying to establish a center down south in the Mindanao area in Davao. So we have partners there, but unfortunately, yes, there are a lot of mission type of surgeries going on in our country. This was a big argument between me and Smile Train because it's like sending mixed signals. On one hand, you're pushing for a comprehensive cleft care, but on the other hand, you're providing funding for a cleft mission. So the only thing that I could rationalize how this system is coming through is that here we are in a transition period. So as one system, the multidisciplinary care type of system is gaining ground, there's still room maybe for the mission type system as it starts to fade away. because I don't think we can do an abrupt stop of one and then just say, oh, we'll stop all this and then have everybody go to a center, because I don't think that's a feasible strategy for our situation here.
Thanks, Dr. Bernard. So that goes back to our discussion off the top about saying all of the sponsors of comprehensive cleft care on this call, are involved some sort of journey towards that sense of year-round multidisciplinary care. And so, as Dr. Fayaz mentioned, as you've mentioned, there is these transitions that are ongoing. And one of the things I was really interested in your model was how you talked about intentionally trying to target gaps within the public health infrastructure and then try to fill those. I wonder if you could say that a little more. And for everyone on the call, what are the gaps in your own context that you feel like are the most important to cover within your local system, and what are some of the challenges that you face? So, Dr. Bernard, can you explain one example of finding a gap that was important for comprehensive cleft care to become implanted, and how you tried to navigate that? And that's actually, obviously you're discussing about that even in this transition period with one of your sponsors like Smile Train.
All right. One of the main gaps that when we started was we have a lot of these unrepaired cases. When they would come to us, when we look into their mouths and there's an unrepaired, and there are a lot of dental caries. And if you try to do a good palate repair, you end up with infection, dehiscence, because the bacteria is all over the place. So here I was trying to find dental care in our setting, and everybody says, oh, it's so expensive. I would write letters, can you help us with these patients? And use all these costs that that had to be met for a patient, and it would vary, of course, depending on the condition. So I ended up having, with all my friends in dentistry, just trying to, can we set up some sort of a system wherein we can make sure that dental care is provided so that the surgeries will go through faster. And if there are no more teeth to save, then we can provide some sort of prosthodontics for these kids. It's so sad. I had a patient as young as 18 who lost all her teeth. Do you imagine you're 18 and you end up with no teeth? It's so sad. So yeah, so that is one of the things that we saw, because all our surgeries were getting delayed because of the need for dental rehab. We had funding for surgeries, but we couldn't do them because of the poor dental condition. So we had to find a way to be able to push through with surgery, make sure that the dental condition is fixed. And looking for partners part was, I think it was godsend, because some of them were just friends that I used to play badminton with, and I go, oh, so you have a pediatric dental center? Oh, partner with us, please.
Okay, so the steps I heard was identifying, what some of the risks or some of the things that were really holding back timely surgeries, figuring out there was no support within the public space at this point, and then reaching out through personal connections to find those official tie-ups or partnerships that could allow more of a multidisciplinary approach to move forward. Is that accurate?
I think that's it was only by, if you try to fix it. For me, in my situation, I think if I tried to fix it within the government setting, it would have taken years because of the slow pace of government action. So the only way is to do it through a government and do it quickly, because the patient really needed it.
Thank you. And if you have any comments or questions, please, the chat is open. And again, we're always keen to hear from people about how they're experiencing this in their own context. We're trying to all learn from one another and moving these conversations forward. Dr. Bijoy, please, what's your question?
Thank you for giving scope. I am Dr. Das from Bangladesh. In our country, there is no setup in government hospitals. All setup in private hospitals. Our experience is same with Dr. Bernard. The adult cleft lip is day by day reducing in number. Though I have no statistics in Bangladesh, so by Smile Train, there is still about 70,000 cleft surgery done. But speech therapy in only one center, and some centers are going to develop. I hope within this year, one or two more centers and one orthodontic center surgeon. But by this year, 2 to 3 surgeons will be added here, and some nutritionists also there. So we are doing the comprehensive cleft services here also. This is our Bangladesh experience.
Thank you for sharing that from Bangladesh. That process again of adding more disciplines into the care being an ongoing evolution, and speech therapy being a key element in Bangladesh. That's very helpful. Dr. Bernard, I'm also interested. Oh, go ahead.
In my center, one counselor is psychologist is here also. She counseled the patients and their guardians about bullying in school of patients.
Right. So that resonates with Dr. Bernard talking about that bullying experience too. That's helpful. I mean, Dr. Bernard, you mentioned this sense of cleft awareness being low in the Philippines in general, and you mentioned that that parents are very reluctant, in your experience, to talk about their clefts with their children. Now, can you explain that a little bit more? Is that because parents themselves have not had access to the right resources, and so then they can't? Or is it more that parents are reluctant to point out that their kids have an anomaly or something different about them? What's your experience?
I think this is a cultural issue. I think this is a cultural issue because there's a saying in the Philippines, I just translated, if you don't talk about it, there's nothing wrong. So if they, I've had parents that I have spent, like I had one parent, she told me she plans to burn all the baby pictures of her child because she was happy with the result and she doesn't want the child to know that he has a cleft. And I spent about 2.5 hours telling her that, you know, we still have to do alveolar bone graft at around 7 to 9. And she has to, your child has to know why we have to do this surgery. And at the end of the conversation, I said, oh, it's been 2 hours, you know, go home, think about it. And I hope when you see me in your next follow-up, we can talk about this with, and you have a plan to tell your child. And she goes, I'm probably not. So after 2 hours, I still couldn't convince her. But
wow.
And yeah, I think it's a fear that if they're not able to, because they haven't been able to be educated about the cleft condition, they won't be able to answer the child's questions. And so this is what we have with our parent group, that they get together and talk about their own experience in helping their children. So with the parent support group, I'm hoping this topic would be brought up more, and I'd see less children who find out that they have a cleft from some bully.
Thank you, Dr. Bernard. Yeah, well, how does that connect to your context? It makes me think. I see Mon on this call from Myanmar. You know, a very trusted a colleague of ours from Myanmar region. You know, she grew up with a cleft lip and palate, but had no idea that that was the name for it. You know, she knew she was told she had some sort of accident. You know, she knew, but it was only when it was sort of reflection from her peers, as you mentioned, that caused her to finally dig in and understand that there is a name for this, and it wasn't some sort of accident that was undisclosed. So thank you for pointing out those cultural pieces that need to be addressed in order for patients to really feel like they're in the loop about what's happening, and you know, especially when you have a major surgery when they're 8 or 9, you know, this is a time when they should be able to understand what's happening. Very helpful.
Hi, good evening.
Oh, Dr. Siddhartha from Kolkata, please. Yeah, what's your question or comment?
Yeah, first I will appreciate that such a nice talk on comprehensive cleft care, and we run on a same model, which is co-funded by Transforming Faces, and I really like the idea of the patient group, because they tend to educate each other. And we are fortunate that the dental facilities here are supported by Transforming Faces. But the only problem is that how do you address the people who are coming late to you where the teeth had already been lost? See, we are providing dental care for all the comprehensive care patients. I think we are doing it with the support of Transforming Faces for the last 4 years. But our own patients are getting good treatment with the age group. But the patients who are coming late to us has already lost their teeth, and they might be needing a distraction or a bridge or a dental rehabilitation. Very difficult to cater these kinds of patients because they will be needing high amount of money for this implant and all these things. How do you approach this?
Yeah, great question. So Dr. Bernard, back to you. What happened? You mentioned this horror story of an 18-year-old losing all their teeth, but how do you address the timeliness issue within your movement?
We try as much as possible to advocate that the child gets referred to us as early as 1 day old. Then our pediatric dentists are very aggressive when it comes to prophylaxis for dental care. So they would go around. They would make sure that before any pediatric dental procedure is done, each parent has to watch a video on how to take care of the dental condition of their child. So that the work that they do will not be useless. But for those who come to you quite late, I think we're in the same situation here.
Absolutely.
It's already quite late. We try to save as much teeth as we can by doing a lot of root canals, but
like in charity, the more you do is less.
So hopefully, it has to be in partnership with our National Dental Association. So I've already lectured there, and I'm trying to get them to be more aggressive when it comes to teaching dental care, because the problem actually with a lot of the general dentists is they're afraid to treat a person with cleft in our country. With the patient would come to us and say, "What happened? How you've already been seeing a dentist?" Oh, they're afraid. They're afraid to treat me because I have a cleft. So again, education of the dental trainees.
So another key topic to think about is, it's one thing for your outreach to work with professionals who might see patients, and so they understand that there is something to be done. That next step, though, is do they have the confidence to actually want to work with cleft patients, or they feel like, oh, this is something either because of, they think it's something for foreigners, or even something they think of, do you have to be a specialist, that they're reluctant to give the care in a timely way. So there's a challenge before you, Dr. Bernard, it sounds like you're trying to address. Now, one of the things, we're getting closer to the end of time, I was very interested in is how you mentioned that your Smile Jeep, this idea of connecting in at the right time and making referrals. You just mentioned the connection to the National Pediatric Dentistry Society, et cetera. How is this idea of going closer to home? How are you making that move forward? And how does the idea of transportation connect into this idea of good referral networks and good relationships throughout the country?
Oh, sorry. I think let me explain the Smile Jeep concept a little bit more. When we started out, we were only getting about our follow-ups were less than 30%, 40%. The patient wouldn't come back after we removed the sutures. We'd tell them, "Oh, come back this time because we have to schedule palate repair. Come back. You need a pediatric consult because your child the weight is quite low." And a lot of them would come back months, years later, and the reason would always be we don't have enough money for transportation. So we linked up with because our problem is with the pandemic, everything went haywire. So before the pandemic, we had linkages with NGOs and local government units. And they would gather the patients, the parents, to a certain spot, the patient that they would meet, and NCF would provide the bus or the van to bring them to our center. So this is what the Smile Jeep concept was. So the parent there would give a share of the transport cost by going to this meet-up point, and half of that, and our share is to bring them to our center. So So it provided almost more than 80% to 90% more follow-ups. And and because of our linkages with the local government units, we the local, like the mayors, and would get to know who we are and would refer patients to us.
Fantastic. So, you know, a topic that we know almost every webinar we talk about, this challenges of transportation, especially for patients who are limited by poverty. You know, that moving around is so challenging. So Dr. Bernard's pointed to a model, you know, of basically a co-payment model where the patients, it sounds like, are responsible to getting to the drop-off point, but from there they know they'll be well taken care of. The Smile Jeep will be part of that. So I guess the question back to your teams, again, thinking about your own context, how are you addressing transportation concerns? You know, how are you addressing this idea of co-payment? Is that something that's part of your model? Is that something you'd wrestle with? Dr. Bernard's pointing to, you said, you know, a huge increase in follow-ups because you introduced this sort of co-responsibility for getting back to a center. Very interesting, Dr. Bernard. Thank you. We're down to the last couple of minutes. I'll just read out Dr. Adiola, who has a huge interest both in surgery and speech therapy. Commendable work. Comprehensive cleft care is the way to go. Better still in the context of interdisciplinary rather than multidisciplinary. And maybe we can spend a webinar sometime talking about the differences between, or what we mean by interdisciplinary versus multidisciplinary. But it sounds like the idea of multiple disciplines working together, Dr. Bernard, is something that's been the key to your growth as NCFP. And I'm really grateful for everyone who's joined on the call. I think, Niti, do you have another slide for us?
Can I put in some last word? Sorry.
Yeah, you do. Yeah, you have time. Go ahead, please.
Okay. All right. Actually, another integral thing that I think that paved the way for our success is the multidisciplinary communication among the specialties. This is quite surprising because I was actually tasked to write a protocol on how to get doctors, dentists, and speech therapists to talk with each other. I laughed when I heard it, but it seems that in other centers they don't talk to each other. So, and in our center it became like an afternoon meeting. So we were all there, and it's an open type of clinic. There are barely any walls. I can go over to the other specialists, like the pediatrician, the orthodontist, and they come over to me and say, "Oh, I have this problem with this patient," and right there and then we got a multidisciplinary meeting. So yeah, I think that's a
great. It didn't come up in your presentation, Dr. Bernard.
Sorry,
close to my heart. I don't think that collaboration is you know, just the norm that people expect. I believe it does require intentionality. And you know, while it might seem ridiculous to write a paper about how 3 disciplines could work together, I think that kind of intentionality is so important to maintain and sustain, because I think our natural inclination is to focus on our own sphere, our own discipline, our own silo, and not be thinking about how it fits into the whole. But as you presented for NCFP, that's been critical. That sense of collaboration and communication is not natural in that sense until you develop those muscles, those skills, and those practices. So I'm delighted to end our webinar today on that concept of thinking about in your own context, you know, how is that collaboration coming? What are your communication practices that will allow you to do this kind of problem solving? Maybe it's about the idea of how to incorporate speech therapy, as we heard. Maybe it's about the idea of transportation. These are things that impact the whole team. And how are you doing right now within your own team in promoting that kind of problem solving communication, and maybe making sure that your patients are getting the best care from a multidisciplinary perspective or interdisciplinary perspective, whichever one you're resonating with. Well, the time is here. Dr. Bernard, thank you for a very insightful conversation. You touched on a lot of topics. We could have gone on for much longer. My question for each of you again is, what's your takeaway? What is the thing that you're going to go back to your team and say, hey, I spent an hour on this webinar this evening, this midday, or this morning, and here is something that came up in the Philippines context that I would like us to think about how it applies to our own context. And Dr. Bernard, you've done a very skillful job of leading us through that. Thank you very much. Great to see everybody else on the call, and we'll look forward to seeing you next time. Thanks for making time for this. We really appreciate it.
Thank you, Dr. Bernard, for this very interesting and insightful presentation. I have an exciting announcement. We have just launched our COCP LinkedIn page. So please go ahead and follow us on LinkedIn. Our page is called Circle of Cleft Professionals, COCP. And if you haven't already, we invite you to subscribe to our YouTube channel, Circle of Cleft Professionals, which is where you can access all of our previous webinars, including this one, which will be posted soon. You can also follow us on X. Our handle is @CleftCircle.
Great.
Thank you, everyone.
Thanks, Niti. And thanks again to
Thank
Linus
you.
and the
Thank
NCF
you.
Taiwan group for making this recommendation and for Smile Train's support, obviously, of Dr. Bernard's team as well. So thank you very much, everyone. Great to see you. See you next time.